Hi, hello. Okay, can I start? Yeah. Hi. Hey guys. So I guess we can start now. So if you're just now walking in or you don't know, go to this little website, sli.do. And then once you do that, it'll pop up like a page, and you're gonna put capital HP and then lowercase si. And it's just gonna be a little poll thing. So we have like 2 hours and we have a lot of questions. So if you have like a personal question, I guess like wait until we're done and then you can come talk to me afterwards about it. But like if there's something like extremely wrong, you can like yell at me and I'll stop and then we can do it. But like a personal question, just like wait a little. Okay, so I guess we can get started. Okay, so before we start, we have like I did the thing last night, my bad, and I found errors on it. So for number 2, there's an F now, and all of the above are correct. I wonder what the answer for that one is. Okay, number 9, it should be hormone is not. And I think that's it. If there's like any other errors, like scream at me and I'll stop and we can go over it. But I guess we can get started now. So when I open the poll, I'll give you like 30 seconds because we have to work fast. So I'm gonna open up the poll and you guys answer number 1 for me. Okay, so I guess we'll stop with that one. So I see a lot of people put D, that's good, and a lot of people put other things. So which of the following binds to a nuclear receptor? So when we're talking about that, it's important we talk about like the types of receptors of hormones. So we know we have like protein hormones, right? And then we could also have cholesterol hormones. I'm the worst at spelling, so don't laugh, I guess. So with protein hormones, we know that the cell membrane has proteins on it that we can bind to it. So for protein hormones, can these pass the cell membrane? No, right? So the protein hormones cannot pass cell membrane, that's what the CM stands for. And they bind to cell surface receptors. Okay, so remember protein hormones, they can't pass the cell membrane, so they have to bind to cell surface receptors on the outside of the cell. That's the first one, and the next one we have is cholesterol hormones. Can cholesterols pass the cell membrane? Yeah, right, because they're cholesterols. So they can pass membrane. And these are going to bind not to cell surface receptors, but they're going to bind to what are called intracellular receptors or nuclear receptors. So the receptors are inside of the cell. So nuclear or intracellular. Okay, so which of the following binds to a nuclear receptor? Prolactin, growth hormone, and insulin, these are all protein hormones. So those obviously can't go to nuclear receptors. And then cortisol can. So I like pictures, so here's a little picture. So we have the peptide hormone. It has to bind to a receptor on the cell surface. And then we know the story, remember, from the adrenergic receptors. So we have alpha-1, stimulates, CAMP, all that stuff. Second messenger, which is usually CAMP, cyclic amino monophosphate, and that's going to tell the gene to transcribe, and then it's going to do physiological function. Okay, that's that in a nutshell. And then cholesterol, or steroid hormones, these pass right through the membrane, and they bind to a nuclear receptor or intracellular membrane, intracellular receptor. Okay? So the answer for that one was D. Okay? So for number 2, I made a mistake. So go ahead and add F to your options. So no, like there's no like mystery surprise anymore. But the answer for that one was F. So which of the following is not true regarding paracrine cells? So remember for the last block how we talked about paracrine cells were like in our GI, and they regulate cells of its neighbors. So if this is a paracrine cell, here's the nucleus. And these are its neighbors. What paracrine cells do is they secrete hormones or whatever they want, peptides, hormones, stuff, and they actually stimulate their neighbors. And these could be effects such as they could block their neighboring cells, so they can like, hey, stop secreting what you're secreting, we have enough. Or they can be agnostic, so they can like tell the cell like, hey, stimulate more. They can be antagonist, which is kind of like, hey, stop doing that. And then somatostatin is a secretion, which we know, right? And then also they could also be called juxtacrine cells. This is also true. So the takeaway message from this is that all these things are true. So 2 is F. Okay. And when we're talking about paracrine cells, it's important we talk about like what are things such as agonist, antagonist, stuff of that nature. So here's a picture. So this is what normally is supposed to happen. So we have like a ligand, a hormone or whatever. It naturally binds to its receptor, and that tells the cell to do its physiological function. But we also have what are called agonist and antagonist. So an agonist is a synthetic hormone. It could be a medicine, a drug, a ligand, and it binds. It's like a synthetic form, not the natural one. So this is a natural one. This is an antagonist. It binds to it, and it enhances its cellular activity, or it promotes the cellular function. So it's kind of like dopamine and bromocriptine. They're kind of like the same, but whatever like dopamine does, it's kind of like bromocriptine could also do. Okay, and then we also have antagonist, and this is the one that like like villain. So what an antagonist does is it binds to like the receptor, but it stops the function. So the antagonist is gonna bind to it, and it won't do any cellular activity. Okay. So that's that. Now let's go ahead and do number 3. And the poll's open. Do we need more time? No? Okay. So, see, a lot of people were getting it right. So let's go ahead and tackle this one. 25-year-old non-pregnant female presents with irregular menstruation, irregular menstruation, ovulation. Sometimes she feels really depressed, vomits, sleep disorder, sweating, we could always just like, meh. Her doctor put her diagnosis as infertility. What would be an endocrinologist's diagnosis? Okay, so looking at these symptoms, irregular menstruation, there's obviously something wrong with her sex hormones. Sometimes she feels really depressed. If you're like a man or a girl and you don't have that hormone that makes you, wouldn't you be sad? Like if you're like a buff guy and you don't have testosterone, that would make you sad. Or if you're like a girl and you don't have estrogen and you're growing facial hair, wouldn't that make you sad? So it's obviously something wrong with the sex hormones. With the sex hormones, we have what's called prolactin in females. What prolactin does is when it's in excess, it'll decrease our sex hormones. It'll decrease FSH, and it'll also decrease growth hormone. So what we can do to tackle this is prolactin is like its antagonist is kind of like dopamine. So when we have increased dopamine, we kind of have decreased dopamine. So what we can do to counteract that is give someone synthetic form of hormone. No. So prolactin, we can give someone bromocriptine, the synthetic form of dopamine. So that'll help relieve the symptoms. So deficiency of serotonin, man, kind of, because if you don't have serotonin, you can't really sleep. But man, that doesn't explain the irregular menstruation. Excess norepinephrine. What do we do? What do we know that norepinephrine does? Yeah, we use it for our autonomic nervous system, specifically the sympathetic nervous system. So we increase heart rate, increased contractility. So she would show signs of like increased heart rate, a lot of sweating, malnutrition, because with norepinephrine we decrease gastric hormone secretion, stuff of that nature. So man, no. Excess serotonin, no. Deficiency of dopamine, yep. And then excess dopamine, no. Okay. So the takeaway message from that one was prolactin. When it's secreted, it decreases our sex hormones and stuff like that. Okay. So let's go ahead and do number 4. Okay, so everyone's putting C, and that is correct. Good job. The reason being, so prolactin, it has a natural antagonist, which we talked about already, was dopamine. And in patients with a deficiency, a synthetic form, bromocriptine, can be used, and we talked about that. Okay. Now let's go ahead and do number 5. Do we need more time? No? Okay. So yeah, I think we hammered down the message of prolactin. So when its levels increase, we see this decrease, and these are considered sex hormones. So these would decrease as well. Okay, so the answer for that one was E. Going back to this one on the subject of antagonist and agonist, so norepinephrine has beta 1 antagonist, which is propranolol. So I'm just gonna leave a little note, beta 1 antagonist. And then for B, we have a agonist, and that's gonna be albuterol, which is beta 2 agonist. Right, so for beta 2, that's the one of the bronchodilation, constriction. So for people with asthmatic patients, we give them albuterol because it bronchodilates, so it's a good thing. And then, yeah. So let's move on to number 6. Okay, do we need more time? No? Okay. Okay, so a lot of people are getting it. The answer for that one was CAMP. The second messenger for GPCRs is going to be cyclic amino monophosphate, which is a form of intracellular energy. So with the reception of hormones, we talked about in class like types of ways that types of receptors that we have. So we have GPCRs, which are the 7 transmembrane domain receptors. We have growth factor receptors, we have cytokine receptors, ligand regulated receptors. So what you should know for those is it's important that just like every other class, if you get acronyms, you should probably learn what they are, because I wouldn't want to write GPCR, what it stands for, on the test, because it's a lot of work to do for me. So like G protein coupled receptors, you have to know acronyms. For the receptors, it's important you should know what binds to them, like what type of hormone would bind to what type of receptor. So for example, with our growth factor receptors, insulin would most likely bind to that one. For our cytokines, we have JAK2, JAK and STATs, stuff of that nature. And second messengers are good to know and stuff like that, and like what they're coupled with. Okay? And GPCRs, the G protein coupled receptors, these are the ones that we usually talk about when we're talking about like alpha 1, beta 2, alpha 2, stuff like that. Okay? So the answer for that one was A, and let's do number 7. Okay, before I answer this one, as you can already tell, I'm going to get your colors out because we're going to draw. Oh, man. Okay, so let's go ahead and talk about the executives of the endocrine system. Okay. So the executives of the endocrine system. So this is our brain, right? We have our corpus callosum. And down here we have our hypothalamus. And then hanging off of the infundibulum or pituitary stalk, we have the pituitary gland. Hypothalamus, and then gland. Yeah. Here's your brain. So it would be like somewhere in here. Okay. So that's our pituitary system. And with our pituitary gland, we have 3 lobes, right? We have the anterior lobe, posterior lobe. Oh, my bad. Okay. Posterior lobe. And then, do we only have 2 lobes of our pituitary gland? No, we have 3, right? Remember the intermediate lobe? Okay, so the president of our endocrine system would be our hypothalamus, right? Because that tells the pituitary gland what to do. And the pituitary gland would be our vice president of our endocrine system. Which is weird because we know that the vice president doesn't really do much in like American government. But so the pathway that connects the hypothalamus to the anterior lobe, we're going to have a blood vessel system, which is called our hypothalamic pituitary portal system. So it's basically just a little blood vessel system that connects the hypothalamus directly to the anterior lobe. So whenever the hypothalamus wants to get something done, the anterior pituitary gland will do it. Okay? And then the next thing is, for the posterior lobe, the way that we connect it from the hypothalamus to there is we have 2 nuclei. We have the supraoptic, and we have the paraventricular nuclei. Okay, and then they secrete 2 hormones, which we'll talk about soon. And they project it into the, they project it through their axons into the posterior lobe. So like the soma would be in the hypothalamus, and then their long axon extends to the posterior lobe. Okay. In the anterior lobe, when the hypothalamus wants something to get secreted, it'll secrete its hormones through the portal system. And then in the anterior lobe, we have what are called trophic cells. And these are the little things that will do its work, like they secrete the hormones. Okay. So with the hypothalamus, these are going to be secreting our releasing hormones. And our pituitary gland is going to be secreting stimulating hormones. And this is all very nice because it all works on a negative feedback loop. So we should have homeostasis all the time, right? And if we have a deficiency in one hormone from, let's say, like the anterior pituitary lobe, if we have a deficiency in that, the hypothalamus will respond by secreting more as to counteract the change, right? Because we always want to resist the change. So the first hormone we have is growth hormone. Let me do a separate page. So this is our hypothalamus. And this would be our pituitary gland. These are our releasing hormones, and these would be our stimulating hormones. So the hypothalamus will secrete GHRH, which is growth hormone, releasing hormone, and that will tell the pituitary gland through the hypothalamic pituitary portal system, right? To secrete growth hormone. Okay, growth hormone we know controls the size and number of cells in our body. It's involved in the cell proliferation and growth, and secreted from the placenta in our fetal life. So that's what helps grow the baby. Okay. If I had a deficiency in my growth hormone, what would I happen to be? Huh? Dwarf. So yeah, short. And then if I had excess, I'd be tall. And sign up for basketball. Okay. The next one is TRH. And this one is our thyroid releasing hormone. This one also goes through the hypothalamic pituitary portal system, right? Yeah. So this one secretes our TSH, which is our thyroid stimulating hormone. And it also does PL, which is prolactin. And we talked about prolactin, right? Don't get that wrong. Next is our CRH, and that's our corticotropin hormone. That'll go ahead and tell the pituitary gland, the anterior pituitary gland, to go ahead and secrete ACTH, which is adrenal corticotropin hormone. Okay, and this is also from our anterior pituitary lobe, right? So it's still through the hypothalamic portal system. In the thalamus? Huh? Kind of, sort of. So it's like, it works on a negative feedback loop. So if I have low, it'll tell my hypothalamus to like, hey, we need some more of this hormone. It'll tell the pituitary gland to, hey, tell your trophic cells to secrete more hormones. Precursors? Can you ask me after? Yeah. Okay. Okay, yeah, we talked about that. And then next one is GnRH. Gonadotropin releasing hormone. Okay, and this is important for our reproductive system, right? We have FSH, follicular stimulating hormone. And then we LH, which is luteinizing hormone. Okay. Can anyone tell me what the posterior pituitary gland will secrete? Oxytocin and what else? ADH, right? And ADH goes to our kidney, and oxytocin does good things, which we will talk about. Okay, so we're all good with this? Does anyone need this? Okay. So, yeah. Know what goes through what connection. So if I wanted to secrete gonadotropin releasing hormone, which pathway would it go through? Would I go through like the, what are they called? The axons? Or would they go through the portal system, stuff of that nature? Okay, so let's go back to number 7. Follicular stimulating hormone gets secreted from blank, travels to blank, and shows its physiological effect. So we know it gets secreted from the anterior pituitary gland, so all of this is wrong. Travels to blank and shows its physiological effect. The answer for that one was going to be A. So we'll talk about the pathway later on, but GnRH gets secreted from the hypothalamus, travels the portal system, right? Goes to the anterior pituitary, and it'll go through to the testes or ovaries, basically your gonads. Okay? Go ahead and do number 8. Okay, so a lot of people, the majority, didn't get the right answer for that one. So I wish I could pull up the camera for you, like the computer, but we gotta work with what you get, so here's my phone. Can you all see that? This is basically just like a, kind of like the female fertility chart with like what's hormones going up, what's happening to her endometrium, what hormones are up and down, and all that good stuff. Okay, so if fertilization were to occur, which hormone maintains the endometrium for implantation? That is going to be progesterone, right? Oh, my bad. And then which one would lead to spontaneous abortion? That one is also going to be progesterone. So let's look at this picture. So you can see menses. This is when she's having her time with the month. So what happens when progesterone levels increase? We see that the endometrium lining is also increasing. And then again, when the cycle's over, on day 0 or 1, we see a drop, and that's when the endometrium gets shed. So if egg were to get fertilized onto the if an egg were supposed to get implanted onto the endometrium and progesterone levels decrease, and the egg was here but it got shed off, wouldn't that lead to spontaneous abortion? Yeah. So, man, Mike died. So the answer for that one was going to be E. And then I guess we can do number 9. My mic died. Hey, okay. Thank you. Oh yeah. So I forgot to mention we're doing number 9, right? Which of the following? I forgot I did an error. So it should be which of these is not made by the hypothalamus. So we know the hypothalamus. This is the one that secretes releasing hormones. So anything that's not that is not the answer. Releasing hormone, releasing hormone, releasing hormone. This was a trick. Hypothalamus does secrete dopamine. So that was also wrong. So the answer for that one was C. And it's okay if you didn't know dopamine was secreted by the hypothalamus, but you should know that ADH gets secreted by the posterior lobe of the pituitary gland. Okay, let's go ahead and do number 10. We're getting into the nitty-gritty. Okay.
C was the answer for that?
Yeah, C.
Are you sure?
Which of these is not made by? Oh my God.
There it is.
Oh yes. Okay, I did a mistake. Wow. Okay, so there wasn't an error. I was right. The answer for this one was C, because remember the hypothalamus makes the hormone, and then it travels down the axon of the nuclei to the posterior. So technically it does make it. So see, I even fooled myself. So it's not it's whatever, however 9 is that's how it is, and it's C. I know, my bad. Okay, but 10, right? Thank you. Do you want a free shirt? Oh man, I'll do. Oh no, pink's not my color. I'll do like a bonus question, and whoever gets it right at the end, I guess, can have it. So study now. Okay, 10, right? Um, which of the following would not cause the renin, angiotensin, aldosterone system to be activated? Okay. So can someone tell me what actually stimulates this to get started, the system? Decrease in blood pressure, right? Anything else? There is one more thing. Decrease in perfusion level in the glomerulus. So basically, like the amount of blood that gets passed from the glomerulus into the nephron, right? Remember we did the kidneys. So which of the following would not cause the renin system, whatever? So these two criteria is the one we're looking for. And so if it has this criteria, it's not the answer because we're looking for not. A patient gets into a tragic car accident with lots of lacerations. So he's going to be bleeding, a lot of blood loss, right? So that's going to cause a dip in his blood pressure. So that's not right. Glomerulonephritis, decreasing the perfusion rate? No. That's going to cause the system to get activated. Cushing's disease? That is not going to cause it. Okay? Can someone tell me what Cushing syndrome is? Is it an increase in so this is our kidney, right? We have a kidney, and then on top of our kidney sits the suprarenal gland. So we have the cortex, and we have the medulla. Renal cortex, renal medulla, same thing. So our cortex is going to secrete what? What? And then the medulla is going to go ahead and secrete what? Good job. Norepinephrine and epinephrine. With norepinephrine, you could switch it with adrenaline, right? So noradrenaline would be norepinephrine, and then adrenaline would be epinephrine. Yeah, so don't forget that. So let's go back. Cushing disease, would that be an increase in our cortex hormones or a decrease? Increase, right? It's not really like a mnemonic, but how I remember is Cushing kind of sounds like crushing. So I imagine like my fist like squeezing the cortex like a sponge and like squeezing out all the juice. So it's going to cause like an increase in all these hormones. So with Cushing's disease, we're going to see increase in aldosterone. What does aldosterone do? That one increases blood pressure, right? Would an increase in blood pressure cause this? Cause the renin system to activate? No. So that's why that's wrong. And then Addison's disease is a decrease in these hormones, right? So if I had a decrease in aldosterone, that would cause me to dip my blood pressure, right? And that would activate it. So that's not wrong. That's not correct. And then during surgery, a young surgeon cuts an artery and lots of blood loss. That would activate it because you're losing blood. Okay, so we're good with that. Let's do number 11. Okay. The answer for this one, 11, is going to be D. Which of these is a catecholamine? D. It's important you should know kind of like code names, not code names, but like groups. So we have like catecholamines you've heard of probably, adrenocorticoids, glucocorticoids. Those are important not just for this class, but if you choose to go on to like take the MCAT and stuff like that. These are kind of like the what is this question you would find. So aldosterone are going to be adrenocorticoids. I always look for a core. That's going to be like signal. It's going to be in the cortex. Cortisol, that one that resolves around like sugar and glucose. So this is a glucocorticoid. Remember, core is referring to the cortex. Insulin, this gets secreted by the pancreas. So I really hope you didn't put that. Oh no. And then adrenaline gets secreted in the medulla, which is a catecholamine. So our catecholamines are going to be our adrenaline, epinephrine, noradrenaline, norepinephrine, all that stuff. So catecholamines refers to the medulla. Okay, let's do number 12. Yeah. Yeah.
I thought that IQ3 was the second messenger of like the phosphoinsaturated signaling system.
For GPCR.
Yeah. Okay, how about you like literally have it divided from phosphorus and second?
I think like that's probably right, but as far as like the probably strategic the second message.
Okay.
I can 90% sure I got it from my notes.
Okay.
But yeah, that could be right. You know, like yeah. So I would go with the bio. But like for this class, you know. Okay, my bad. I made another mistake. What question was it? 6? Yes. 6. This one is going to be. I have in my notes. So for the G protein coupled receptors, are used in adenylate cyclase, so AC, calcium calmodulin, and IP3. So I'm a failure, and the answer for that one was B and C.
On the BRS, it also mentions CAMP.
It says it, let's see.
Yeah, I see it here. It says, for example, cyclic or mono. It's because like AC moves to.
Okay, this is a bad question because in the BRS it says G protein coupled in the cyclic, adenosine, monophosphate. So CAMP is the second messenger. Man, that's a bad question, I guess. I would go with the slides because that one you can kind of, I mean, you can put both and kind of like fight which one. But I would, if I were in your shoes, I would probably go for the IP3 and AC because that's the ones like directly in the notes. But yeah, I guess that was a bad question. So CAMP is BRS, and then these two are in the slides. Okay. We're on 12, right? The majority of the class dot C. That is correct. Okay. A 35-year-old Caucasian female presents to the hospital alarmed by her recent truncal weight gain, facial hair growth, thinning skin. During the physical examination, the physician finds that the patient is hypertensive. What was this? Truncal weight gain, facial hair growth. During the physical exam, serum analysis reveals hyperglycemia. Which test results would confirm the patient to have Cushing's disease? So Cushing's disease is an increase in the 3 hormones of the cortex, right? Androgen, aldosterone, and then cortisol. Okay? So increased CRH decreases aldosterone. No, right? That one stimulates it, so this would be increased. B, increased body hair. Yeah, she had facial hair growth. That's not cool. Decreased blood sodium level. No, right? Aldosterone in the renin system. Let me just show you a quick picture. That one pulls in sodium, right? And we expel protons, right? So potassium and hydrogen. Okay, so this is like the renin aldosterone the system in a nutshell. So we're gonna pull in bicarbonate, we're gonna pull water, sodium, and chlorine, and then we're gonna expel potassium and hydrogen. So the question said decreased blood sodium level. No, we have an increase because it's going inside of our blood. Okay? So that's no. Again, increased. And then irregular menstruation and increased adrenocorticoid levels. Yeah. Right? Because androgen, that's a sex hormone that's going to cause her to be manly and not have periods. And then increased adrenocorticoids, remember core is the one that stands for the cortex, and that's what secretes all these 3 things. So C is correct. Hypokalemia, no, right? Yeah, hypokalemia, that's true. And then hyponatremia, no, she's gonna have hyper. Blood pressure check would come up normal. No, she would have hypertension, and she did have hypertension. Okay, so the answer for that one was C. Okay, so we're good with this. Number 13. Okay. Do we need more time? Mm. F isn't an option. No. So thyroid hormone plays which of the following effects? Can you guys hear me? So dumb. Okay. Okay, yeah, good job. Okay, thyroid hormone plays which of the following effects? Oh, this is a YouTube one. My bad. You're all wrong. So ossification and fusion of cartilage. That's bones. Maturation of the PNS. That's going to be our CNS. And then remember, so with this one, this is the one that would cause mental retardation in a baby if the mom has whacked up thyroid glands. Has similar effect to the parasympathetic system. This is the sympathetic. The correct answer for this one was going to be D. Yeah. So I want to talk about C for like a few minutes, like the sympathetic. It mimics the sympathetic system. What do we know for someone who has hyperthyroidism? They have increased heart rate, increased sweating. What else? Anxiety. They're like meh, like flustered. And then with someone with hypothyroidism, they're slow, sluggish, low blood pressure, maybe depressed, sluggish, right? So they're kind of like opposites. So with the sympathetic, it mimics the sympathetic system because if you have excess sympathetic stimulation, your heart rate increases, you sweat a lot, you have anxiety, you have increased blood pressure, right? So with hyperthyroidism and think of the sympathetic system and then you can kind of like figure out the symptoms. Okay? So the answer for that one was D, increased body temperature. Okay? Number 14. Okay. 14, good job. The answer for that one was D, all the above. Remember how I said you need to know acronyms? PTH stands for parathyroid hormones. Here's a picture of them. So this is the posterior view of the thyroid gland, and we have 4 little P-shaped glands, our parathyroid glands. Okay, and they have a role in calcium, right? So with calcium, we know it's important for action potential, right? And it's also important for muscle contraction. Yeah. Yeah. Huh? I can't hear you. My bad. Mm, yeah. Acts to increase calcium levels in which areas? Oh, my bad. Is the what I meant by the question was like, how does parathyroid hormones increase calcium in our blood? And that's kind of what I meant. But it targets these three areas, right? Because where do we get calcium? From our bones, right? So we can pull calcium from our bones. If we have low calcium in our blood, we can pull it from our bones. We can get it from our diet, right? So we can eat something with calcium, like milk, and parathyroid hormone will tell the intestines to, hey, pull calcium from the milk or whatever. It could target that. And then in our kidneys, we can pull calcium from our urine, ions. So acts to increase calcium level. So it increases calcium levels by targeting these three areas. Okay. Let's go ahead and do number 15. Okay. To stimulate the secretion of insulin by beta cells, glucose travels to blank. By this, we see an increase in intracellular energy in the form of ATP. By this, we see a blank. Okay? So, I guess I'll draw the picture for you. Um, that's our blood vessel system. Here is our cell. Can someone tell me the normal level of blood glucose level in your blood? 120 milligrams per deciliter, like 70 to 120. So anything above that would be hyper, and then anything below that range is hypo. So we have glucose in our blood. It's going to travel through GLUT2 receptors. By doing this, GLUT2, once inside, it's going to close off the potassium channels. So I'm just going to draw like a K. So it's going to block off the calcium channels. So 1, 2, it blocked off the potassium channels, and that's going to keep the potassium inside the cell. And by doing this, we're going to see an increase in calcium into the cell. Potassium remains inside the cell. This leads to depolarization, opening the calcium channels. The increased contraction of calcium forces the vesicles full of insulin to leave via exocytosis. So by an increase in calcium, we're going to see a vesicle of insulin get secreted into the blood. Okay, so glucose will travel through the GLUT2 receptors. So that's wrong, that's wrong. We see an increase in intracellular energy in the form of ATP. By this, we see increase in intracellular potassium. Right, because potassium can't leave the cell, so it's going to stay high. Yeah? GLUT4, that's the one of how this is how we uptake glucose, right, from our blood. So insulin binds to its receptor. By that, it's going to stimulate GLUT4 receptors to go to the surface, and that's going to pull glucose in. So GLUT4 is pulling glucose in by the result of insulin. And then GLUT2 we use for insulin exocytosis. Okay? So the answer for that one was C. Let's go ahead and do 16. Say that one more time. After the exam. Do you know if I'm supposed to tell them about a survey? I forgot to mention, there's like a survey at the end of tables. If you could go ahead and scan that with your phone, I guess, and it's gonna like take you to a survey. If you didn't like me, I guess write a review, and then if you did like me, write a review. I don't think, just go ahead and do the survey. I forgot to mention, but yeah, I would appreciate it for feedback. Okay, so the answer for number 16 was going to be C, glycolysis. So let's talk about this one. When you go eat something, what does your blood sugar level do? It will increase, right? So when you're starving, your blood sugar is low, right? So you eat something to increase it. So if your blood sugar is low, this would cause your body to secrete glucagon, right? Because glucagon acts to increase your blood sugar level. So in hopes of increasing blood sugar levels, glycolysis is the process of glycogenolysis. That's the process of making sugar, right? So if you're making sugar, you're gonna put it into your blood, and that's gonna increase your sugar levels. So glycogenolysis is the breakdown of glycogen into glucose. Glycogen into glucose, and glucose would increase your blood sugar levels, right? Yep. So that is wrong, because it would. Gluconeogenesis is the process of making glucose also, right? Genesis means synthesis, and then gluco. So you're making glucose. And that would also increase your blood sugar level. What do we know about glycolysis from exam 1? That is breaking sugar down, glucose, into pyruvate. And then pyruvate goes through the citric acid cycle. And we get electrons from that. I just took a test on this, I forgot. And then from citric acid cycle, we go to electron transport chain, and we get ATP. So if you have a low blood sugar level, would you want to cut glucose? No, right? If you have low sugar, you need to keep all the sugar you have. So it would do all the following except glycolysis. Glucose into pyruvate. So the answer again for 16 was C, because glucagon acts to increase blood sugar levels. And how could we increase our blood sugar levels if we're cleaving sugar into pyruvate? Okay. Now let's go ahead and do 17. I only have 7 responses. Do we need more time? Okay, I'll give you a minute. And if you don't know, I guess just put put F, I guess, so it like tells me that you don't know, so I can talk about it more. Okay, I guess we'll talk about this one. So, 17. A 14-year-old Caucasian male of normal weight presents for a well child checkup. During physical examination, his parent states that his son has been frequenting the bathroom, polyuria, more often than usual, and his weight has decreased despite an increase in his caloric intake. Which of the following most consistent with their son's symptoms? Could someone tell me what this boy has? Huh? Yeah. Diabetes type 1, right? And what is type 1 diabetes? Is it because insensitivity of the glucose, or is it the autoimmune of like destroying your beta cells? That one, right? So type 1 diabetes, we would find someone who can't secrete insulin, right? And what about their blood with glucose? Hyper or hypo? Increased, hyper. They go to the bathroom a lot, polyuria. They drink a lot of water, dipsia. What else do we have? So with this, so you know how we said like when you're eating food and that like all your food gets like converted, not all your food, but like food gets converted into glucose, and that goes into your bloodstream. And usually, normally you would secrete insulin to decrease your blood sugar level, but with type 1 diabetes, you don't have insulin. So what ends up happening to break down, to get energy, because we use the glucose in the bloodstream to get energy, right? We pull it into our cell, we go through glycolysis, we get ATP, and we get energy. But the problem is we're not getting glucose into our cells. So when we can't use glucose, what's our next option? Attack the fatty acids, right? Our adipose tissue. So that's why this boy is losing weight, because the glucose isn't getting used for energy, so he's going to go ahead and attack his fat reservoir, which is his adipose tissue. That's why he's losing weight. So I guess this one was tricky, but you should have guessed that the boy had type 1 diabetes. And increased insulin secretion, was that the case? No. Self-reacting T cells, that's kind of indicative of autoimmune. So that was the answer, B. I made these really hard. Like, this was probably like way too hard that you would probably see, but it's good that if you could have answered this one, then you should be good. Absence of leukocytic infiltration into the pancreas, no, because there was leukocytes, that's what destroyed his beta cells. Hypoglycemia, no. And then amyloid deposits in the pancreatic insulin cells, no. That's just like random. Okay, so the answer for that one was B. Um, 18, this one is like kind of like unfair too, because we didn't really talk about it, but it's good. I'll save 18. If you can answer 18, I'll give you the free shirt if you get it correctly and explain why. So I guess I'll hold on to that one till the end. So TBA, because that's a good question. Okay, 19. With type 2, that one's kind of like, we can secrete insulin, but it's kind of like the insulin's not binding to the receptor. Differentiating it, I guess you could say kind of like, you wouldn't have, let me see the options. Let me go see the options and I'll come back. I guess that one's kind of like a bad question because it's kind of like they have the same signs and symptoms. The only difference is the cause.
Okay, so just like looking at the answers would help you.
Yeah.
Because there's really nothing else that it could be.
I mean, because if it was type 2, then A would be correct, right? Because
Yeah.
like if we have like a lot of sugar in our blood, like our body would react by secreting more. So I guess yeah. I mean, I guess now, like in hindsight, I guess A and B could be correct, but yeah.
Okay, just wondering.
Yeah. Okay. Okay, did we get 19? Okay, aspirin and some other drugs can target enzymes that use which of the following as a substrate? So, we have a nice lipid bilayer, right? And so when we have like a bacterial infection, we know we have something that's not supposed to be there, like a virus or like a bacteria, a pathogen. What that pathogen does is it multiplies out of control, and it could damage our cell membrane. So we get from the damaged cell membrane, we get arachidonic acid. And then what our body does is it uses an enzyme to convert it into prostaglandins. So this is why, like, if we have like a cold or a flu, like we're sick, this is why we have a fever, right? Because the pathogen that's in us is destroying our cells, and our cells are going to release arachidonic acid, and they're going to secrete, they're going to get converted into prostaglandins. Prostaglandins travel our blood, go to the fever center in our brain, and that tells our body to, hey, raise the temperature. The enzyme that converts arachidonic acid is going to be our cyclooxygenase, our COX. We have COX-1 and COX-2. So the enzyme is going to be our cyclooxygenase, but a substrate is the ligand that binds to the enzyme. So the correct answer for that one was going to be B. Okay, and then so when we have a fever, we take an aspirin, right? An aspirin, what it can do is it can block the COX, the cyclooxygenase enzyme, and that's going to prevent arachidonic acid from going into prostaglandins, and the prostaglandins from causing the fever. So the answer for the 19 was B. Okay. I guess we can do 20 and 21 together. Like you can couple them because they're the same question, and I'll give you a minute. So I guess we'll do 20 first. Okay. The answer for this one was going to be B, placenta. And the reason being is because for the first 2 months when you don't really have the placenta, that one is going to be the corpus luteum. So when you're pregnant, you know how you have trimester? So it's kind of like 9 months. You divide it by 3. So the first 3 months is the first. The second 3 is the second. And the last trimester is like the last 3 months. So in the first trimester, you don't really have the placenta fully developed first yet. So you're going to have your corpus luteum is the one that's going to be secreting it. And then for the last one, it's going to be the placenta when it is created. Okay? So for 20, the answer was B, and then 21 is going to be C. Go ahead and do number 22. Okay, let's talk about this one. Which of the following statements about prolactin is correct? Prolactin initiates ovulation. That's going to be LH and sort of estrogen, right? So that's not right. Prolactin causes milk ejection during suckling. No, that's oxytocin, right? Prolactin has a role in forming the milk, and then oxytocin is the one that helps eject the milk. So that one is wrong. Prolactin inhibits the growth of breast tissue. This is, we'll come back to that one. Prolactin secretion is tonically inhibited by the hypothalamus. This one is true. Right? Because the thyroid releasing hormone, that's the one that secreted it. So if we have an increase, excess in prolactin, that causes a negative feedback loop to tell the hypothalamus, like, hey, we have a lot, can we not make more? And that'll stop the thyroid releasing hormone, and that'll stop the thyroid stimulating hormone, and that will stop the prolactin secretion. Prolactin inhibits the growth of breast tissue? No, because prolactin helps make the milk, right? So it's going to stimulate the growth of breast tissue. And then prolactin secretion is increased by dopamine. No, they're opposites, right? So it would be decreased. Okay? Number 23. For 23, the correct answer for that one was B, thyroglobulin. Thyroglobulin. I was going to show you an animation on the computer, but I can't really do that because the computer. But on my website of the SI, I kind of put an animation. That one, if you could watch it like twice or 3 times and you just like understand what's going on, that should be good enough for you. But you trust me, it is B. And we have 30 minutes to do a lot more questions, so we have to like pick the pace up. Okay. So 24, PGE2 leads to that one is going to be vasodilation. So remember with prostaglandins, we have different types that we can convert to. So with arachidonic acid being converted by the enzyme cyclooxygenase into prostaglandin, with PGE2 we have smooth muscle relaxation and vasodilation. So PGE2 leads to vasodilation. Okay. Oh, my bad. Did you guys hear that? Yeah. Okay. So 27 we can do together. A 27-year-old Caucasian female presents complaining of recent weight loss and weakness. She reports that she feels dizzy and lightheaded every morning when she gets out of bed and often at work whenever she must rise from her desk. Physical exam reveals several areas of her skin, including her elbows and knees, are more pigmented than others. That's the big sign of Addison's disease, right? Which of the following would be consistent with this patient's disease? So weight loss, and we have weakness, pigmented, that would be Addison's disease. So with Addison's disease, we know we have primary, which would be an increase in CRH, an increase in ACTH, and a decrease in all those cortical hormones. With secondary, the problem would be on the pituitary or the hypothalamus. So we would see a decrease in CRH, and then we would see a decrease in this, but we would also have a decrease in these as well. So which of the following would be consistent with this patient's disease? Hyperglycemia? No, because we would have hypoglycemia because of the cortisol. Hyperkalemia? Yeah, because remember on the renin-aldosterone system, usually we're supposed to push potassium into our urine, right? Because we want to excrete protons. However, when we have a decrease in this, we're going to actually keep more in our blood, not excrete it into urine. So that one's right. Hypernatremia. With a decrease, that one we're going to push salt into our urine, and that one gets expelled out, so that one's wrong. Central obesity, that one's more of Cushing's. And then pretibial myxedemia, I don't know what that is, so. That's what it was? Oh. So it's still wrong, right? Yeah. Okay. So that was a bad question. I get them from like a weird book that I have. Oh yeah. Mhm. I guess this one's a bad question too. It was supposed to be Addison's disease, but I guess this one was like thrown in there, so I guess I shouldn't have included that one. But what I wanted you to pull from this one was it's Addison's disease, and then with Addison's disease we have hyperkalemia because we're not excreting potassium through the renin-aldosterone system. Huh? Um, I have no answer for you, but I just know like from listening to, huh? POMC. According to the lecture, um, decreased MSH comes from POMC from intermediate lobe of pituitary gland. So this is the lady, poor lady. And then hyperpigmentation because of decreased MSH comes from POMC from intermediate lobe of pituitary gland. Okay? Yes. Okay. So now we did endocrine system. Now we're gonna do the immune system, which is very short. For your test, I think she said like 1 or 2 questions. I don't remember if I had any, if anything, but it's still good to talk about. So which of the following is not a mechanism of the innate immune system? If you haven't taken immunology, I guess going through the study guide, that would be good enough. And if you have taken immunology, I wouldn't really worry about it because it's very simple. So the innate immune system, that's the one of the first, that's the one that we're born with. So it's very basic, so like phagocytosis, complement system, stuff of that nature. So microglia in the CNS phagocytose a pathogen, this is true. A leukocyte releases a chemokine in response to a pathogen. This one is also true. The hypothalamus responds to PGE2 to cause a fever. This is true, we can cause a fever. If you're sick and you have like a pathogen inside of you, there's a reason why our body will increase the body temperature. The first reason being that so we know that E. coli, or not like E. coli, but like a pathogen, they grow at like a certain temperature. If you increase that temperature, that would kill them, right? Because they like to be at the optimal temperature. That's one reason why we do that. And the next reason is because temperature, when we increase our body temperature, that increases enzymatic activity, right? So by increasing the enzymatic activity, we're going to make our body work faster and more efficient and kill the pathogen. So that's why we have a fever. So to increase temp, we kill pathogen because they don't like to be in hot temperatures. And then we increase temperature to increase enzymatic activity. Okay, complement system activates to lyse a serratia S. I don't know what this one is, just serratia. This is true, and then a mature cytotoxic T cell specializes to destroy the serratia. This one is not a mechanism. This is a mechanism of our adaptive immune system. This is why when we get sick with one type of illness, we don't get infected by it again, because we can grow immunity. Okay, which of the following is not a cell in the adaptive immunity? So we know our B and T cells, these are the ones of the adaptive. Our B cells will secrete antibodies. And then they can get activated to turn into plasma cells, and that's like the mass production of antibodies. Our T cells, these are our specialized killer cells. I can't spell specialized. Killer cells, and then our NK cells, these are a part of our innate immune system. Okay, so the answer for that one was C. Okay, number 28, what is not true regarding antibodies? They tag a pathogen and degrade it. No. Do antibodies, do they destroy pathogens? No, they just tag for opsonization. And that's basically like if I have like a foreign body, or like let's say someone who's not supposed to be here, I could tag them. Like if I have like a gun with like a laser, I can kind of like target them, and then that'll tell the phagocytic cell to come and destroy them. And antibodies, when they bind to pathogens, it like helps the phagocytosis process. They have a heavy chain and a light chain. This is true. Antigen binding site. This is true. And then a protein. This is also true. And then IgG is the most common in the blood. True. Okay, what initiates the complement system? So we can have 2 IgGs, or we can also have 1 IgM. That's what activates the complement system. And I was planning on showing you a video and animation on the complement system, but we only have 15 minutes and we have a lot more to do. So go on my website, and there's a nice little animation, and that could summarize it for you. Or after the review, I'm going to post the answers to the study guide. You can do that on the study guide as well. Okay, which of these is not an example of an autoimmune response? So an autoimmune would be like our body attacking ourselves. Not good. So myasthenia gravis, this was one, right? This was when our immune system attacked our ACH receptors. Oh my bad. So with myasthenia gravis, this was the one of it destroyed our ACH receptors. So I'm sorry, I'm breathing into the mic. But like the acetylcholine couldn't bind to the receptor because we had antibodies blocking the receptor, remember? Type 1 diabetes. This is destruction of your beta cells in your pancreas. So that is not one. Type 2 diabetes, is that caused by autoimmune? No, this is kind of like acquired through life, kind of. And then joint pain and abdominal pain. Remember, I just wanted to throw these in there to remind you of like symptoms. Would be like if you have joint pain and abdominal pain, that would be because you have antibodies in these regions that would cause these pain. So if I had joint pain or abdominal pain, that could be attributed to my body secreting antibodies to these regions. Okay? Um, 31. A 33-year-old male presents with acute appetite, nausea, and sleep apnea. Among other things, him and his wife tell you they are trying to have a kid, but no luck. When his wife steps out of the room, he confides to you he has decreased sexual drive, he feels depressed and tired after working out. A head scan reveals a tiny, very cancerous mass near his pituitary gland. Looking at his symptoms and the results of the MRI, what could be found? So this is the problem of this guy is he has decreased testosterone, right? We all agree on that? So decreased testosterone. That explains acute appetite, nausea, sleep apnea, the infertility, that explains that. When his wife steps out of the room, decreased sexual drive. Because increased testosterone, that does libido. He feels depressed. Remember we said if you don't have what makes you you, you would feel depressed. And tired after working out, because testosterone is involved in muscle stuff. So with decreased testosterone, we have what's called, we have a system in our body. So everything physiological is homeostatic, so everything has to be homeostasis. So when we have a decrease in testosterone, that's going to tell the hypothalamus to increase GnRH, and by increasing this, we're going to increase our LH, and then so on and so forth. So are we going to have if the problem is he's not secreting testosterone, the issue is probably somewhere in the Leydig cells. So if he has decreased testosterone, would he have increased Leydig cell secretion? No. Increased GnRH? No. Decreased FSH levels? Wait. Yeah, he would have increased. My bad. Yes, he would have increased. Because if we have a decrease, we're going to go in hopes of increasing it because we know everything homeostasis, negative feedback. If we tip the balance, we need to fix it. So this one's right. And then we would have decreased FSH levels. This doesn't really do much for us of testosterone, so that's wrong. And then in decrease inhibin, meh. And these are also false because if we're increasing our GnRH, that's gonna increase our FSH. So we would see increased FSH and we'd also see increased inhibin. So that's also wrong. Okay? So our hypothalamic pituitary gonadal axis is very important. Okay, the thyroid gland is derived from which of the following? Ectoderm, mesoderm, endoderm, and epidermis. This is our skin, so I hope you didn't think that. And then, so we should probably talk about our embryonic germ layers. So have you ever heard of like, if you like go on like random facts or something, it's kind of like, have you ever heard of like, at one point in our life we were just like a butthole and like a mouth? Yeah, because we were at like a neural tube, and basically, you don't need to know, I mean you do, but like basically in embryonic life we're basically conformed of like 3 little layers, and these 3 little layers determine our body. So the ectoderm, this is the one that's going to make our CNS, PNS, our epidermis layer of the skin, our auricles and our eye and our ganglia. Our mesoderm, this is the one of muscle. I always do the M and M, so meso and muscle. So everything of the muscle, so the smooth cardiac, the skeletal, the dermis layer of the skin, connective tissue. This will do our testicles, ovaries, and kidneys. And then for our endoderm, this one does the entire GI, except the mouth and the butt. And with the GI, it's kind of like that and all the associated organs, so like the liver, pancreas, stuff of that nature, and that also includes the thyroid. So the answer for that one was C. Okay, so it's important, you should know, if I give you a structure, you should probably tell me what it came from. Okay, a 4-day-old healthy male infant is born with normal internal and external male reproductive organs. Karyotyping analysis reveals a 46 XY genotype production of what substance by which cell is responsible for the development of normal male seminal vesicles, epididymis, and that. The answer for this one was going to be D. The reason being is because the Mullerian inhibitory factor, it gets produced by the Satori cells, yes, but it suppresses the default development of like the female stuff. So it doesn't really do much for these. It does more of the female stuff. So this is true, but it's more of like the females. We said D was true. C is wrong because the Sertoli cells don't produce testosterone. They produce the Mullerian inhibitory factor, which will suppress the female reproductive organs. So this was wrong because Sertoli cells. And then testis determining factor. This is on the SRY gene. And they don't really have a role in that. So the answer for that one was D. Because we know testosterone, that one commits us to going down the male pathway. Okay? 34. A 22-year-old female presents to the clinic at the beginning of her third trimester for a fetal ultrasound. She tells you everything is fine except she occasionally is woken up at night. The sonographer is unable to visualize any of the structures arising from the mesonephric duct. This infant is at risk of which of the following malformations? So with our mesonephric duct, what does that produce? Like, what does it eventually get turned into? That one will commit to male organs, right? Like I have epididymis, vas deferens, and seminal vesicle. So if you don't see the mesonephric duct, that either indicates you're a girl or you're going to be a messed up guy. So the answer for this one was no malformation would be expected because the mesonephric duct, that one does male body parts. So if you don't see those male body parts, you're fine if you're a female. Okay? Make sense? Okay? This one's long. A 32-year-old female presents to her gynecologist noting that she missed her menstrual period 2 weeks ago. She denies pelvic pain, but notes that she has a very regular cycle and typically does not miss periods. She is concerned and states that she would like to have an abortion if she is pregnant. A pelvic ultrasound is performed, which shows no sign of gestational sac in the uterus, and her human chorionic gonadotrophin levels have been randomly checked several times this month. The levels have been moderate enough to be indicative of pregnancy, but not high enough to be in the normal range. Other hormones involved in pregnancy have been checked and appear to be in normal range. Which of the following is true? So, is she pregnant? No. Does our body naturally secrete or like make HCG if you're not pregnant? No. So she has to be pregnant, right? Because if you have some sort of levels, and they said that it's high enough to be indicative of pregnancy, but it's not like a normal level. So we're going to walk through this, but in the end I'm going to tell you what was wrong with this female, and then it all makes sense. So teratoma, tumor of the egg. No, she would have a lot more signs. She would have like abdominal pain and stuff like that. Ovary is producing progesterone. Is that true? Yeah, right? The corpus luteum, that's, okay, well, I'll just tell you. She is pregnant. The reason she has low levels is because she has what's called an ectopic pregnancy. So you know how it's like the egg gets fertilized, travels down the fallopian tubes, and it implants onto the cervix? However, with ectopic pregnancy, the egg gets implanted in somewhere it's not supposed to be. So the fallopian tubes, for this case, I guess. So that explains why she has low levels of HCG. Because if she has HCG, she has to be pregnant. But the reason they're so low is because it goes from the fallopian tubes all the way down to like where her urine. Whereas the levels would be higher if it's in her cervix. Okay? And then what do we know? So she is pregnant. So what do we know secretes progesterone the first few trimesters? Which is in the ovary, right? Yeah. And then spontaneous abortion has occurred? No. Because we said other hormones involved in pregnancy have been checked and appear to be normal range. So if she had a decrease in progesterone, that would be spontaneous abortion, right? But they're normal? Yeah. Okay. Which of the following hormones in female is high during ovulation? Again, I'm going to pull up this picture. So this is an important picture. ovulation is when the egg gets pushed out, and then that's time for pregnancy. Which of the following hormones in female are high? So here you can, if you could see maybe. The LH levels are high. You have to trust me. And then the estrogen levels are also high. But the progesterone levels are kind of low, but they're rising, right? Because when progesterone is rising, that's when we're increasing our endometrium layer, so we can have implantation. So the answer for that one was D. So the takeaway message was look at that chart and kind of like not like be able to like draw it or anything, but it's kind of like understand what's going on and the hormones and stuff. We only have like a minute left, so 37 is out. If you have a question about one of them, I guess you can come to me and we'll talk about it. But corpus albicans has been synthesized. Which hormone are rising in circulation? That is going to be this one and FSH. And refer back to the chart that I showed you, and that one would explain that. Okay, can we all see this one? A 5-year-old boy presents for a regularly scheduled checkup. The child is wheelchair bound due to lower extremity paralysis, suffers from urinary incontinence, partial blindness, and deafness. At birth, it was noted that the child has lower limbs and disproportionate small size in relation to the rest of his body. A radiograph imaging at birth also revealed several abnormalities, yada, 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 underdeveloped cochlear system. The paralysis and some other symptoms were caused by tough labor. However, for certain symptoms, a complete history and physical performed on the child's birth mother during her pregnancy would likely have revealed which of the following. So through all of this, I wanted you to pick out blindness and severe deafness and underdeveloped cochlear system. This is possible if a mother is pregnant and she takes amoxicillin. I probably spelled it wrong. But she talked about it in lecture. If you're pregnant, you shouldn't be like dancing around, partying, drinking alcohol, stuff of that nature, because we know that leads to bad things. So the answer for this one was C. And the reason is because when you take amoxicillin, it's an antibiotic that targets the ear, the inner ear and stuff of that nature. So it's going to go ahead and target the baby and get the ear. Okay, and then 39 is the answer for that one is going to be E. And then for 40, the answer is D. Okay. Because the sperm ultimately, if you have a question, you can come talk to me, and then we'll like find out why they're wrong, because I tricked you in like all of these, and then this one you have to look at the pathway of sperm from spermatogonia all the way to sperm, and that'll explain why. Okay.